I think you usually expect a medical diagnosis to come with this um, neat little blueprint.
Right, like a very clear, fixed problem.
Exactly. You point to a scan, you see the physical plaque blocking an artery, and you say, okay, there's the problem.
Yeah, we clear the pipe, the plumbing works again.
Right. It's a very comforting way to view the human body.
Hmm.
I mean, we really crave that binary structural fix.
It makes perfect sense that we lean into that plumbing metaphor, honestly, because in classical cardiology, assessing risk has historically meant looking for a fixed obstruction.
So if the artery is clear, you're fine.
Right, ostensibly fine, and if it's blocked, you intervene.
But if you read the clinical guidelines from the Japanese Circulation Society, alongside the latest guidance from the British Menopause Society, this startling through line emerges that just completely shatters that plumbing metaphor.
It really does. It flips the whole paradigm.
Today on the deep dive, we are stepping into a diagnostic landscape that isn't a static blockage at all. We're looking at your cardiovascular system not as a series of inert tubes, but as this dynamic network that's intimately tied to your endocrine system.
Yeah.
Specifically, our mission today is exploring how fluctuating estrogen levels dictate the frequency and intensity of these sudden, violent vascular spasms in women.
So the condition we're focusing on is called Prinzmetal's angina.
Okay.
It's also frequently referred to in the medical literature as variant or vasospastic angina. And the mechanisms behind it really challenge everything we intuitively assume about how heart disease presents.
Right.
And, more importantly, how different physiological systems communicate with each other in real time.
Well, let's start by defining that clinical picture, because Prinzmetal's is decidedly not the standard. I jogged up a steep flight of stairs and my chest hurts kind of angina.
No, not at all. That classic presentation is stable angina. That's where exertion increases the heart's demand for oxygen and a physical plaque restricts the supply.
The clogged pipe.
Exactly. But Prinzmetal's happens when a coronary artery suddenly goes into a severe spasm.
Oh, well.
Yeah, it violently tightens and narrows, basically choking off the blood supply to the heart muscle entirely on its own.
So the clinical texts often describe it as an unprovoked transient constriction.
Right. I think the most accurate way to visualize it is to imagine getting a severe Charlie horse muscle cramp.
Ouch.
But instead of it occurring in your calf muscle after a heavy workout, this paralyzing cramp is happening inside the smooth muscle of the actual arteries supplying your heart.
That is terrifying.
It is. And the defining characteristic of this condition is its timing. Like, these attacks almost exclusively happen when a person is at rest.
Wait, really? While they're resting?
Yeah, they frequently occur while the patient is fast asleep, usually striking between midnight and early morning, and it just wakes them from a dead sleep with this crushing chest pain.
Which is just a terrifying reality to live with. So to understand why an artery would suddenly seize up while the body is entirely at rest, we have to look at the inner lining of the blood vessels, right? The endothelium.
Exactly. The underlying biological flaw here is endothelial dysfunction.
Okay.
So in a healthy cardiovascular system, the delicate endothelial cells lining your blood vessels are constantly synthesizing and releasing this molecule called nitric oxide, or NO.
And nitric oxide is a vasodilator.
Right, it's a potent endogenous vasodilator. Its primary job is to act as a chemical messenger, continuously telling the smooth muscles of the artery wall to relax and stay flexible.
Okay, I follow.
The problem is, in patients with Prinzmetal's, this system breaks down. The endothelium just fails to produce or release enough nitric oxide, which leaves the artery hyperreactive.
So without that constant chemical signal to relax, the vessel is just prone to these sudden contractions.
Yes, exactly.
But if this comes down to an artery failing to produce nitric oxide, why are we zeroing in on estrogen today? I mean, men have endothelial cells too, so presumably they suffer from these spasms as well.
Well, men absolutely do suffer from vasospastic angina, but the epidemiological data paints a profoundly different picture depending on sex.
So,
There was a 1998 nationwide survey conducted by the Japanese Circulation Society. They looked at tens of thousands of patients and revealed this fascinating timeline. For men, the incidence of these spasms generally climbs in a steady, linear fashion as they get older.
okay, so it essentially tracks with typical cardiovascular aging.
Right, just the slow accumulation of endothelial wear and tear.
So for women, the graph must look entirely different then. If we're talking
Yeah.
about estrogen, the incidence rate probably stays relatively flat in their 30s and 40s,
Yeah.
and then violently curves upward right around the age of 50.
The curve shoots up dramatically, almost precisely at the half-century mark. The onset of these severe heart spasms spikes exactly when a woman's women's reproductive hormones begin shutting down.
Die in perimenopause.
Exactly. That demographic data from Japan was the smoking gun for researchers. It suggested that estrogen isn't just a background reproductive hormone, it acts as a primary mechanical shield for the heart's vascular network.
To understand how a reproductive hormone physically alters the behavior of a blood vessel, we really have to look at this pivotal 1999 study published in the Journal of Clinical Investigation by Chen and colleagues.
Yes, that's a crucial one.
They were investigating estrogen receptor alpha, right? And they discovered that the enzyme responsible for manufacturing nitric oxide.
Right. Endothelial nitric oxide synthase, or ENO.
Yes, ENOS. It's directly controlled by estrogen.
So when estrogen binds to those receptors in the blood vessels, it essentially flips the switch on ENOS, signaling the enzyme to just pump out nitric oxide.
Wow.
Yeah, as long as sufficient estrogen is circulating, the arteries receive a steady flow of that relaxing molecule, keeping the smooth muscle compliant and preventing spasms.
Wait, this is where the classical understanding of hormones hits a wall for me?
How do you mean?
Well, hormones are supposed to be these slow systemic messengers. We're taught that a hormone enters a cell, travels all the way to the nucleus, binds to the DNA, and alters gene expression to build new proteins.
Right, the genomic pathway.
Exactly. And that genomic process takes hours, if not days, to manifest. A coronary spasm lasts maybe 5 minutes. So a slow-acting, DNA-altering hormone simply cannot intervene in a sudden, violent muscular contraction.
That paradox baffled endocrinologists and cardiologists for years, honestly, because the genomic pathway you just described, that is how hormones build tissue and regulate long-term cycles.
Right.
But the 1999 study by Chen's team revealed something completely revolutionary. Estrogen has a secondary non-genomic pathway.
That's a physiological fast track.
Exactly. They discovered that 17-beta-estradiol, which is the most potent estrogen in the human body, causes an acute, rapid activation of ENO in literally 5 minutes flat.
5 minutes.
5 minutes. It completely bypasses the nucleus and the DNA reading phase.
So instead of going into the cell's nucleus and rewriting DNA, it hits a receptor on the surface that triggers a MAP kinase cascade.
Yes, exactly.
It's like pulling a fire alarm. The signal bounces instantly from protein to protein, forcing the cell to dump nitric oxide into the artery in seconds.
Right. The MAP kinase pathway acts as a rapid signal transduction system. The estrogen molecule binds to a membrane receptor, which triggers a series of proteins to rapidly add phosphate groups to each other.
Cool.
And this chemical chain reaction instantly phosphorylates the ENOS enzyme, turning it on immediately.
So estrogen acts more like the active suspension system in a luxury car.
Oh, I like that.
Yeah, it isn't just sitting there structurally. It's constantly reading the road minute by minute, making micro adjustments to the tension and the shocks.
Or in this case, the arteries.
Right. So the system stays perfectly smooth regardless of the immediate stress.
That active suspension analogy captures the mechanism perfectly. Estrogen is providing real-time, on-demand vasodilation. It keeps its hand directly on the tension dial of your coronary arteries.
So if estrogen acts as that minute-by-minute active suspension system, keeping the tension perfectly balanced, we really have to look at what happens when the tension dial is manipulated naturally.
Which takes us straight to the menstrual cycle.
Exactly. The Annals of Internal Medicine published this incredible piece of research in 2001 by Dr. Hiroki Kawano. His team wanted to see if these natural hormonal fluctuations actually altered the physical behavior of the heart in real time.
Right.
So they tracked premenopausal women suffering from variant angina throughout their entire menstrual cycles.
And the methodology of Dr. Kawano's study was remarkably thorough. They didn't just ask the women to log their symptoms. They physically measured the flexibility of the patient's arteries using a technique called flow-mediated dilation.
How does that work?
Well, they use an ultrasound on the brachial artery in the arm, temporarily restrict the blood flow with a cuff, and then release it to measure exactly how much the artery can naturally expand in response to the sudden rush of blood.
Which makes perfect biological sense. So if they are tracking these women through a standard cycle, the frequency of those spasms and the stiffness of the arteries must have spiked in the late luteal phase and early menstrual phase.
Right, exactly when estrogen levels plummet.
Wow.
Yeah, the clinical data mirrored the hormone levels flawlessly. During the transition from the end of the luteal phase into menstruation, when estrogen drops to its absolute lowest point, the ischemic episodes were at their highest.
That's incredible.
Furthermore, the flow-mediated dilation measurements showed that the arteries physically stiffened up. They could not dilate properly to accommodate blood flow.
And I'm guessing the opposite was true when estrogen was high.
Exactly. Conversely, during the follicular phase, when estrogen levels surge to their peak leading up to ovulation, the frequency of heart spasms dropped to its lowest point, and the arteries demonstrated healthy, flexible dilation.
So the active suspension system was essentially going on and off duty with the monthly hormonal tide, and the vascular system was just paying the price.
Precisely.
Well, if a temporary drop in estrogen during a monthly cycle causes the arteries to stiffen that noticeably, the perimenopause transition is where this temporary glitch becomes a permanent baseline.
Yeah.
I mean, the menstrual cycle is a monthly roller coaster, but menopause is when the track fundamentally changes elevation forever.
Exactly right. During the perimenopause transition and then solidifying in postmenopause, that protective 17-beta estradiol declines permanently.
Wow.
So women lose this rapid non-genomic MAP kinase activation of nitric oxide. Without that active suspension system constantly regulating the tension, endothelial function becomes chronically impaired.
Arterial stiffness just increases as a permanent state.
Right.
And it isn't just the physical stiffness either. The cascading metabolic effects really compound the issue. Because without estrogen's broader protective influence, we see LDL cholesterol, the atherogenic kind, begin to rise.
And visceral fat starts to increase.
Exactly, creating a highly inflammatory environment.
Which is a physiological perfect storm. It explains exactly why that 1998 Japanese survey showed such a massive sudden spike in Prinzmetal's attacks for women in their 50s.
Makes total sense.
The sudden, permanent withdrawal of estrogen leaves the coronary arteries hypersensitive, inflamed, and just highly prone to seizing up.
Okay, so if the underlying machinery to make nitric oxide is still sitting there inside the blood vessels, but the chemical signal has vanished, introducing hormone replacement therapy should technically restart the system, right?
In theory, yes.
It's like jump-starting an assembly line. The factory floor is completely intact, the ENOS enzymes are ready to work, but the foreman retired. HRT puts a new manager on the floor, and production should immediately resume.
And the clinical evidence strongly supports that exact outcome. Our sources highlight a crucial study by Dr. Kalantaradu involving women with premature ovarian insufficiency, or POI.
Right.
This condition provides a unique lens into estrogen's role because these are women, often in their 20s or 30s, whose ovaries abnormally stop functioning decades before natural menopause. So they experience a profound estrogen deficiency really early in life, putting them at severe premature risk for cardiovascular disease.
So you have a patient population in their 30s who are suddenly walking around with the vascular profile of someone in their late 60s.
Precisely. When researchers measured their arterial function using the flow-mediated dilation technique we discussed earlier, the results were just stark.
I can imagine.
Their vasodilation was significantly lower than healthy control subjects of the exact same age. Their blood vessels were already abnormally stiff, but the researchers then initiated a 6-month regimen of hormone replacement therapy.
Okay, and what happened?
After just 6 months, their flow-mediated vasodilation increased more than twofold.
Wait, it doubled.
More than doubled. It returned to perfectly normal values, completely indistinguishable from the healthy women who did not have POI.
6 months to completely reverse the physical stiffness of the arteries and bring the assembly line back to full capacity. That is wild.
And this restoration directly suppresses the violent spasms we see in Prinzmetal's. Dr. Kawano, the same researcher from the Annals of Internal Medicine who tracked the menstrual cycles, he conducted another study focusing on provoked attacks.
Provoked attacks.
Yes. He took postmenopausal women and used hyperventilation to intentionally trigger angina in a clinical setting.
That sounds intense.
It is. Hyperventilation causes respiratory alkalosis, which lowers ionized calcium in the blood and forces the smooth muscles in the arteries to contract. It's a highly effective way to trigger a spasm.
Okay.
But he found that estradiol supplementation actively suppressed these hyperventilation-induced angina attacks. The estrogen was so potent as a vasodilator that it literally overrode the severe chemical stress of the hyperventilation.
Wow. Which really forces us to ground this science in real-world application for you, the listener. Because understanding the MAP kinase pathway is fascinating, but recognizing how this presents in your own life is critical.
Absolutely.
The British Heart Foundation materials point out something that gets missed far too often. Heart disease in women, particularly vascular spasms, frequently presents atypically.
Yeah, we've all been conditioned by decades of medical media to think A heart attack or an angina episode looks like a man clutching the center of his chest.
Right, experiencing agonizing, crushing pain that radiates down his left arm.
Exactly. But for women, especially during the hormonal chaos of the menopause transition, the symptoms of vascular distress can be dangerously subtle and incredibly easy to misdiagnose.
It might manifest as profound, sudden, unexplained fatigue,
Yes.
or it could be a wave of dizziness, profound nausea, or shortness of breath while doing incredibly light activity like just folding laundry.
Or sometimes the discomfort doesn't even hit the chest at all. It presents as a dull, throbbing ache in the jaw, the neck, or the upper back, feeling more like severe indigestion or a pulled muscle.
And the true danger lies in the overlap with perimenopausal symptoms. A woman in perimenopause goes to her doctor with sudden breathlessness, severe fatigue, palpitations, and night sweats.
Right.
Because she happens to be 50 years old, those symptoms are immediately categorized as hot flashes, anxiety, or simply the unavoidable discomforts of menopause.
Exactly. A doctor looks at a 50-year-old woman reporting that she wakes up at 3 a.m. with her heart racing, feeling short of breath, and immediately writes a prescription for an anti-anxiety medication.
But anxiety does not restrict the blood flow to your heart muscle.
No, it doesn't. The symptoms of microvascular or vasospastic angina can perfectly mimic traditional menopausal symptoms, but they require entirely different clinical interventions.
Right.
While the British Menopause Society guidelines do note that HRT is not a blanket cure-all, and its use must be carefully individualized.
Especially for patients with established structural cardiovascular disease, right?
Right, or severe hypertension. But for many women, initiating HRT near the onset of menopause serves a vital, direct cardioprotective role by restoring that baseline nitric oxide production.
Understanding that your blood flow is literally altering due to these hormonal shifts gives you the vocabulary to take these symptoms seriously.
It really does.
If you have sudden breathlessness, palpitations, or unexplained jaw pain that wakes you up in the middle of the night, you know now that your vascular system might be crying out because its active suspension system just went offline.
Yes.
You have the knowledge to seek prompt medical care and ask a cardiologist to specifically evaluate your endothelial function rather than just accepting a quick diagnosis of general anxiety.
Armed with this understanding of the non-genomic pathway, patients can actively advocate for themselves. They can specifically ask their physicians about variant angina and request that their hormonal status be factored into their cardiovascular risk assessment.
It is a profound shift in how we view the body. We started today by breaking down Prinzmetal's angina, moving away from that static, clogged plumbing blueprint to uncover a dynamic, sudden spasm of the coronary arteries driven by endothelial dysfunction.
Right.
And we explored the cellular mechanics of estrogen, revealing its non-genomic MAP kinase pathway that forces the rapid production of nitric oxide in 5 minutes flat.
Keeping our blood vessels constantly relaxed and open.
Exactly. We follow the clinical data through the roller coaster of the menstrual cycle, seeing how the natural drop in estrogen acts as a monthly trigger for these painful spasms.
And how the permanent drop at menopause leaves the heart chronically vulnerable to arterial stiffness.
Finally, we looked at how restoring those hormones through targeted HRT can jumpstart the assembly line, reversing arterial stiffness and suppressing these attacks, underscoring exactly why women must never ignore atypical cardiovascular symptoms during midlife.
It's so important.
But before we wrap up this deep dive, the clinical guidelines in our stack leave us with a really fascinating, lingering question.
Oh yeah, this is interesting.
The texts note that vasospastic angina doesn't always exist in a vacuum. It is closely linked to other conditions that involve severe, unprovoked blood vessel tightening.
Right.
Specifically, patients with variant angina show high comorbidities with debilitating migraines and Raynaud's syndrome.
Where the blood vessels in the fingers and toes painfully constrict and turn white in response to cold or stress.
Exactly. So if estrogen's rapid, non-genomic manipulation of nitric oxide is the hidden hand behind these coronary heart spasms, it really forces us to reconsider these other conditions.
Definitely. Could monitoring and managing our daily hormonal tides be the master key to unlocking and treating these other debilitating, seemingly unrelated vascular conditions?
Could a severe migraine simply be a Prinzmetal spasm occurring in the vascular network of the brain?
It's an incredible thought.
It really is. Our bodies are not a collection of static, isolated pipes waiting to be unclogged. It is a deeply interconnected system. And understanding the hormonal tides that pull at it might just change everything about how we treat vascular disease. Something to think about the next time you experience a random symptom that might not be so random after all.